I'm going to talk about upper extremity DVT. This isn't a very sexy topic from a surgical standpoint, but hopefully you'll pick up some tidbits for really what's a reasonably common consultation you'll get as a managing inpatients. So now, management of for upper extremity DVT, it's an increasing problem. It now accounts for about 8 or 10% of all cases of DVT, and it used to be only about 2%. So it's definitely increasing, and it's thought to be that the frequency is increased due to the increased use of central venous catheters in an inpatient setting. It's got an equal male and female incidence, except for recurrent upper extremity DVT, which is more common in females, and subclavian vein effort thrombosis, or Paget-Schroeder syndrome, which is more common in males. Like any DVT, it all boils down to Virchow's triad: hypercoagulability, stasis, and intimal injury. These are the precipitating factors. About 20 or 30% of these cases are considered primary upper extremity DVT. One large category of those is Paget-Schroeder syndrome, which we've already heard about, so venous or venous thoracic outlet. The typical pattern of presentation here is spontaneous onset, the dominant arm for the reasons you've heard described, the history of strenuous activity, and these are young, healthy people in general. There's also patients who have intrinsic vein disease for unknown reason, so they don't have thoracic outlet, but they have some intrinsic venous lesion which precipitates a primary axillary or subclavian vein thrombosis. Overall, the primaries are about 20 or 30% of all upper extremity DVTs. This has been described, and Dr. Nguyen is going to describe the surgical management of this, so I'm going to let that go here. But about 25% of all upper extremity DVT cases are Paget-Schroeder syndrome, or so-called effort thrombosis. The anatomy has been reviewed already. About 90% are in the dominant arm. As I've said, these are young, healthy patients. And the morbidity, the problem with this condition, is somewhere between 7 or 46% of these patients will have functional disability, decreased quality of life because of post-thrombotic syndrome of the arm. So that's what treatment's aimed at preventing. On the other hand, if we go back to all cases of upper extremity DVT, about 70 or 80% are so-called secondary thrombosis, so no intrinsic venous lesion or disease, but rather the result of another factor. The great majority of those are central venous catheters. So obviously they've caused damage to the intima, they cause some element of flow obstruction, and it's also thought that the axial osmolarity of the infusions which go into the central veins can impact the formation of thrombus. Another large category which is analogous to the central venous catheter is patients who have pacemakers or AICD wires. And then these patients, then there's a whole category of patients who have trauma patients, cancer patients who have PICC lines, and other risk factors for secondary thrombosis, such as hypercoagulability and malignancy. Actually, studies that look at all patients who have central venous catheters, actually a pretty sizable portion of them would have an asymptomatic thrombus, probably about 20 or 25%. Now, most of the time it's not symptomatic, so it only becomes a symptomatic thrombus in about 2 to 6% of the time. And then the conditions that also are thought to precipitate or synergize with the existence of the indwelling central catheter are some infection, some malignancy, renal failure, or some history of a prior lower extremity DVT. It tells you the patient may have some hypercoagulable issue. So these are sicker inpatients with central lines who get this condition. So how do you prevent it? Actually, this is actually an area that has almost no guidelines. So there's no specific guidelines for upper extremity DVT prevention. Basically, what you should do is prevent upper extremity DVT just like you prevent lower extremity DVT based on, for example, American College of Chest Physicians guidelines. Mostly involves pharmacologic prophylaxis. When you think about patients at risk for an upper extremity DVT, obviously your choices about the central venous catheter then become important. So in general, central venous catheter should be as small as possible, with as few lumens as possible. And the tip of the catheter placement is really important actually in precipitating upper extremity DVT. It should not be up in the lumen of the subclavian vein. PICC line should not end in the axillary vein. The tips of the catheter should be in the largest vessel possible. So that's either the SVC or the SVC atrial junction. Now, what about, you might ask the question, well, a lot of inpatients have central venous lines. Do they need, why not just give them routine pharmacologic prophylaxis for DVT, even if they don't have any other indications? Or let's say they're an outpatient getting treated for cancer. Actually, the College of Chest Physicians actually right now recommends against that. So there's no indication for preventative pharmacologic prophylaxis if you have an indwelling central venous catheter. So what's the clinical presentation of a patient with upper extremity DVT? Well, almost all will have some element of venous distension, and then they have all the symptoms you see there. They'll have a painful, heavy, swollen arm. And actually, this condition in its most profound form can be limb-threatening. There's also then a certain percentage of these patients who come subacutely, and it'll be a more chronic presentation. And you can see this picture here of a, not a acutely swollen, tense cyanotic arm, but rather a more mildly edematous arm. Without a lot of skin changes. That's the sign that there's been an upper extremity DVT in the past, but probably not acutely. So what about the diagnosis of this condition? I always find this is actually one thing that makes it very easy, because I find this whole D-dimer thing in lower extremity DVT to be incredibly frustrating and useless. But the good news is that D-dimers definitely cannot exclude upper extremity DVT. So this is an imaging diagnosis. Imaging is definitely required, and you have a lot of options: duplex, CT venography, formal contrast venography, and MR venography. If you look at some of the the relative advantages and disadvantages of the different studies, the different types of imaging studies, basically ultrasound's probably the most practical and the most widely used. It's obviously inexpensive and non-invasive, but it's got the disadvantage of seeing below the clavicle or below the sternum. So you might not be able to detect the most central stenoses. CT and MRV, on the other hand, can detect thrombus anywhere, including in the more central veins that can't be examined or visualized with duplex. These are just examples of things you might see, and you can see in the upper left, the engorged jugular vein on a CT. You can see the typical appearance in the lower left of a IJ thrombus on duplex, distended, non-compressible vessel, no flow through a segment, and an acute hyperechogenic thrombus visualized. So in terms of a diagnostic algorithm, you should start with a duplex. If it's negative, but you still have a high clinical suspicion of something more central, then you need to move on to either a CTV and an MRV. I think most surgeons are probably more facile with CTV. You can see the relationships to surrounding structures, I think, a little more readily than MRV. If it's a positive test, obviously you treat. Or if it's incomplete or non-diagnostic, then you obviously have to move on to another study. So what about this condition? What's the prognosis and the complications? Really, because these are sick patients with other conditions, the one-year mortality in these patients is 40%. So you have to think about that when you're talking about, when you're recommending anticoagulation or thinking about interventional therapy. About 10% of them will have a symptomatic PE. It's actually a lower PE risk than a corresponding lower extremity DVT. But if you actually looked, if you did VQ scans or CT venograms of the chest on these people, you would find that a lot of them actually had small asymptomatic PE. Then the other problem is recurrence. Relatively low recurrence rate, about 2 to 5% per year. The real problem here is post-thrombotic syndrome, chronic pain, edema, functional limitation. The incidence varies pretty widely. Unlike lower extremity DVT, a compressive sleeve for the arm has actually not been studied in upper extremity DVT, but it makes reasonable sense that these patients should be elevated and compressed, just like in the lower extremity. So what if you have due to a central venous catheter? In general, the removal of the catheter should take place. And people say, you'll get questions from a medical ICU team. Well, do we start anticoagulation and then pull it? Or when I pull out the catheter, will it flick a clot into it, turn it into a PE? That's really unknown and very unlikely to happen. What should be happening? It should really be the offending catheter should be removed immediately after diagnosis before treatment. If for whatever reason treatment's been started, it can be held for removal of the catheter and then reinitiated. So what about a situation where the central venous catheter is really considered to be crucial or life-saving, like cancer and chemotherapy? What should happen is you should give anticoagulation while the catheter is maintained. If it's viewed that there's no option to take the catheter out, anticoagulate the patient while it's still in, and then another 3 months after the catheter is removed. And actually, studies of this approach show that very few have PE, very few have recurrent DVT, and very few get thrombosis of their line. So then there's endovascular therapy here, and the whole goal is to prevent post-thrombotic syndrome. Usually that's catheter-directed thrombolysis. And what we know about catheter-directed thrombolysis is it definitely reduces the risk of residual thrombus by a lot. So the rationale is early recanalization of the vein, and it definitely does that. But what's not been shown actually is that actually treating it this way reduces your long-term post-thrombotic syndrome. There's really very little data on this. So I think the ACCP guidelines for thrombolysis I think probably guide the way most surgeons practice. And I think I'd reserve thrombolysis for really severe symptoms, a ton of clot, acute symptoms, less than 14 days, and this is a young patient with good life expectancy and a functional status, and they have a low bleed risk. If they don't meet those things, they're probably just better managed with anticoagulation. Percutaneous mechanical thrombectomy, you can add to thrombolysis. I think one thing people talk about, angioplasty and stenting. I think just a couple things here. Like thrombolysis, angioplasty and stenting has not been shown to prevent post-thrombotic syndrome or recurrent DVT. Basically, you have to make the diagnosis here. So you can clear the clot with lysis. It lets you make the diagnosis of venous TOS. And so angioplasty is really only supportive, either preoperatively or postoperatively, of surgical decompression. Stents are virtually contraindicated here, I'd say, because you're putting them in a thoracic outlet, say in a subclavian vein. They're universally going to be crushed, and they're universally going to cause more problem than they can help, I think. So here's an example of DVT, lysis, an intrinsic lesion treated in order to keep the vein open with angioplasty, shows venous TOS, and it goes eventually undergoes repair. SVC filters, you'll get a lot of consults from medical folks. Well, do they have an upper extremity DVT? Do they need an SVC filter placement? I think the basic answer is, unless there's a contraindication to anticoagulation or progressive PE in the face of anticoagulation, the answer is no. This is a little more complicated than an IVC filter placement. You have the SVC is a short, fat structure, and your risk of embolization from a malplaced filter or strut perforation is really, it's not insignificant. So I think most people would, be fairly conservative about SVC filters and really reserve them for exceptional circumstances in placement in the hands of people who have good experience with angiography and placement. You can see here that you can expect a good outcome here, a before-after picture, a very tense, swollen arm with good outcome after appropriate endovascular therapy and anticoagulation.